Hello, everybody, and thank you for joining us today. We have a very special guest, Vonessa Costa, who is the Director of Multicultural Affairs and Patient Services at Cambridge Health Alliance. Vonessa, thank you. Wanted to ask you a few questions. First, how did you fare under the COVID-19, and what are the lessons learned that you suggest organizations put in place to prepare and be better prepared for ensuring language access during situations like COVID?
Well, thank you for having me, Mila. It's such a pleasure to join your podcast. COVID-19 is a story in progress for us. We're happy to say that in Massachusetts we have reached our plateau, but for about 6 weeks we were in a very intense peak period. And we had to learn our lessons on the fly because there was nothing really that could have prepared us for a pandemic. That said, we've learned some lessons that I'm happy to share with your audience today. At Cambridge Health Alliance, we have a very large language access program. We have about 100 interpreters on staff. 58 of them are full-time. Pre-COVID, 22 were in a dedicated call center where we insourced the bulk of our video and phone interpreting, and the rest were spread across 3 hospital campuses where they would give priority to in-person interpreting, and in their downtime log on to video and phone to support the call center. Pre-COVID, on a typical day, we would get about 1,000 requests internally, and we would handle about 70% of them with our in-house team. What we found with COVID, as our ambulatory sites quickly transitioned from in-person visits to phone and video telehealth visits, that we had to make some rapid adjustments, both in service delivery and in the physical locations of our interpreters.
Very, very interesting. So what are the solutions that you have implemented, and what are the challenges that you saw with making that adjustment?
Sure. So as our clinicians were struggling to figure out how to treat patients, COVID and non, during the pandemic, we were also looking at where our interpreters were based in-house. We were particularly concerned about the call center interpreters. They sit, the 22 of them, side by side in cubicles in a lovely off-campus call center, and we were very concerned that just one COVID infection could take out a chunk or the whole call center at once. And so we looked at how we can transition, or how we could transition that group to work from home. Our current platform is structured on a Cisco system, and by buying a VPN license for each Cisco video phone, we enabled the interpreters to take their video phones home and simply plug them in via a data cable to their router. And as long as they had a private, quiet space in which to work and a broadband internet connection, we approved them to temporarily work from home. We also extended this arrangement to some of our campus-based interpreters. So at our 3 hospital campuses, interpreters were sharing a communal office at each campus, and we had more interpreters than we could really accommodate if we were going to implement physical distancing of any sort. And so we asked for volunteers to stay. We wanted to make sure that we had a minimal staffing level for any in-person requests that might come up during COVID on campus. And we asked for volunteers to go home. So within 72 hours in March, we were able to transition 22 call center interpreters and an additional 26 hospital-based interpreters home. And so in all, 48 out of 58 regular staff are working from home currently.
Wow, that required amazing organization, and I believe must have been very stressful, required working around the clock.
It was. We definitely felt a sense of urgency. We wanted to make sure that every interpreter was safe, and we also wanted to make sure that we had the right number of interpreters remaining, and that the people that chose to stay on campus felt comfortable in that decision. So there was definitely a sense of urgency, and it was probably the most eventful 72 hours of my life, except perhaps the birth of my son. I don't
Oh
think
my
I've
goodness.
so much emotion in such a short period.
Wow. Do you feel that any of the solutions that you have implemented are going to remain post-COVID and were actually a good solution that you wished you had all along?
That is a great question, and it's one that interpreters talk about. I can tell you a little bit about the transition and how the organization was also transitioning to a telehealth model. And then I can tell you a little bit about plans to reopen for in-person visits. So the transition of interpreters to work from home actually went very smoothly. Most interpreters were able to bring their device home, plug it in, and have it working all on the same day. Some interpreters realized that they didn't have the quiet or private environment that they needed, and they had to do some reconfiguring of the home workspace. Other interpreters realized they didn't have the right internet connection. And in the first days, when everyone was working from home, some of the major internet service providers actually experienced blackouts and outages due to the high volume of people trying to establish connection in the same neighborhood or in the same building. So we did have a few bumps at the very beginning. Some interpreters did purchase more broadband or a higher level of internet. Others had to work with replacing routers or other equipment. So it took about a week and a half to get everyone really settled and to make sure that everyone's equipment was working. During that time, our ambulatories, we have 15 clinics that are associated with our 3 hospitals. They had closed within a day to in-person visits, and they were beginning to see most of their patients by phone, and they were looking at how to implement Google Meet as a telehealth platform. We are a Google organization. We were already using Google Meet internally to meet with colleagues across campuses or interdisciplinary work groups. So we had some experience using it internally. Immediately, the organization started looking at how can we integrate Google Meet with Epic, which is our electronic health record, with MyChart, which is the patient portal, so that we can do video visits with patients. That was going to be interesting. That was going to require a different workflow. Our previous workflow was that our phone and video requests would come to us on our Cisco phones, no matter where the provider was in the organization. And so because Cisco and Google Meet don't quite integrate, we had to establish a few workarounds to make sure that we could connect interpreters via audio and via video when those televisits were happening. And that also went very smoothly. I think the biggest question in the minds of interpreters working from home is how long will we work from home? And in the beginning, no one really knew what course the virus would take locally. In the beginning, we thought, okay, maybe the work from home arrangement will last a month, maybe 2 months. But as Massachusetts begins to reopen with very strict guidelines about shared spaces, it's now looking like the work from home arrangement will continue through Labor Day, if not beyond. The organization is encouraging folks who can do their work from home to continue to work from home, even as our ambulatory sites look at how they can safely reopen for limited numbers of inpatient visits. There isn't a plan to reopen to full capacity during the summer because of physical distancing, because of PPE, because of practical considerations around that. So it looks like telehealth is going to be something that continues on into the future. Providers have had very interesting experiences with it. Yes, video visits are virtual face-to-face experiences. On the patient side, there isn't digital equality. Not every patient has the right internet connection. Not every patient has a computer or a tablet. A lot of patients are on mobile devices. Some are prepaying as they go. Not everyone has unlimited data. Not everyone wants the provider to have a portal, a visual portal into their home. And so some patients have said, no, I don't really have a private space for a video visit. Others have said, I don't really feel comfortable with a video visit looking into my home. I'd rather do phone. Others are saying, I'm okay. Just book me into your first inpatient visit as soon as the clinic reopens. I'll be there. So there's quite a diversity of patient experience when it comes to telehealth, even though the integration of the interpreter has been relatively seamless. So I think that there's an element of telehealth that will continue into the future, even when interpreters return to the office or to campus. I think there are patients for whom video visits work really well for certain ailments, and there are others that would need to be seen in person. And there are others that would want to be seen in person. So I think that moving forward, we're going to continue telehealth and also see those patients in person again. And for interpreters, our ultimate goal is to bring everyone home to the office from their home office, but we don't really have a hard and fast timeline. We're planning to continue as is through Labor Day.
Interesting, and a great point that you're bringing up about digital equality. So do you think that these new rules and regulations that are being enforced now, social distancing for safety, do you think this helped or hindered language access for your patients?
I don't think it's an apples to apples comparison. So, at CHA, the system is very robust. Any patient calling in who requires language assistance is going to have an interpreter conference into the line. So our interpreters for years have been helping patients navigate the process of calling in to the hospital, of accessing an on-call provider or booking an appointment or asking questions about financial assistance. That piece hasn't really changed. I think the struggle for patients is that there are individuals who always prefer to come in person. And at a time when hospitals are not receiving visitors and are not seeing very many patients in person, these patients are forced to use the technology that they might not have been comfortable using before. And for some patients, that's a big change, and it can be a frustration. And for other patients, it's not a change at all because they were comfortable calling. In terms of language access, we're set up so that language access can be provided in person, by phone, or by video on demand anywhere that the patient and provider are. I think what's changed is that right now many of the providers are not on campus, and the interpreters are not on campus, and the patients are also not on campus. And so when you do have a telehealth visit, there are differences. One I mentioned earlier is you have a visual into the provider's home sometimes, and the provider may have a visual into the patient's home, and that can be both interesting and disturbingly intimate. There may also be a visual into the interpreter's home. Previously, when there were distractions, for example, a baby crying, it was always the patient's child. Now it might just as well be the provider's child. We've had both experiences, where the providers are also struggling with quarantine and confinement and how to make working from home work for them. And I do know that, as the physical distancing restrictions are eased and we figure out how to do this safely, more providers will also be coming back to the clinics and back on campus and perhaps conducting some televisits from a co-location space that is also an office space. But this idea of everyone is at home and yet we are meeting has been a challenge, I think, for some patients, for some interpreters in some situations, and for some of the providers as well.
So it's interesting how the social distancing and this so-called isolation or staying at home actually brought us closer together in a way by bringing us into each other's home and making us see each other in a more human way and being more accepting of both providers and patients and interpreters, having families and kids. That's an interesting change.
Some of the interpreters have commented that they feel a change in the providers. Some providers who were known for being brusque or all business, for being curt, they're actually staying longer. They're having more quality and sometimes more quantity time with patients, deeper conversations. There seems to be more of an empathy on the provider side, because I think this is the first time providers have experienced, a major change in how they work. And a lot of kindness towards the interpreter. Interpreters said that, some providers who used to just hang up at the end of a call or walk out of the room are taking the time to say, "Thank you, interpreter, and I hope that you're well. I hope that you're staying safe." And so there seems to be a lot of goodwill and a shared empathy that may have been there before, but there wasn't occasion to voice it or express it. And providers are definitely more intentional in how they express their appreciation now.
Wow, that is great. That is absolutely great. So my last question is, what would be your advice for maybe other hospitals, other organizations, other language service companies on how to make sure that the interpreters are best prepared to meet the type of challenges that they're experiencing now?
I think the two biggest challenges for interpreters, because in Boston there are a lot of hospitals, and so I've been talking to a lot of other language access coordinators. Institutions that didn't have in-house call centers struggled more, because suddenly face-to-face interpreting was gone, and that was all their interpreters did. And the phone and the video was always handled externally through vendors. And so suddenly the vendor volumes are up, and the staff interpreters are being furloughed, or they're being redeployed, or they're in the office, but they don't have ways to help because in-person interpreting had been so severely limited. Some of those hospitals were able to quickly find a platform and kind of cobble together a way for interpreters to work from an office or to work from home. But if the interpreters had never done phone or video interpreting, then there's a whole learning curve that goes with that. The Boston area hospitals that had internal call centers that were already insourcing a lot of their phone and video requests to their staff, they had an easier time because the interpreters didn't really have to learn something new. They just had to adapt to a different environment. And I think that's what made it easier for Cambridge Health Alliance, is that we've been doing our own phone interpreting since 2008. And we introduced our own video interpreting service in 2012. And every staff interpreter, no matter where they were based, had experience at CHA in the three modalities: in-person, video, and phone. And so it was really just getting used to a new environment, and for the campus-based interpreters, getting used to PPE. But they weren't struggling with how to stretch their skill set across modalities. So my advice, as hospitals anticipate a second wave, is to look at how can you route some of your calls, if not most of your calls, through your own team. How can we make the best use of those spaces in between face-to-face assignments so that the interpreters get the experience with interpreting remotely, and also so that providers and patients get that quality that only comes through working in-house with your staff. Because I think it's not that staff interpreters are more qualified, it's that they have context, they have belonging, and there's a value in belonging that translates easily through the modalities.
Wow, great. Thank you so much. And thank you for your time today. Really appreciate you joining us, and stay safe.
Thank you, Mila. You too.